Hi, my name is Jeff Lee and I'm a periodontist from Toronto, Canada. To Dr. Park, the Megagen family, my fellow Knights, and anyone watching, I hope you are all doing well and healthy, and getting back to practicing dentistry safely. Today I'm presenting a case discussion with the theme of minimizing chair time, which I think is very important given the current pandemic situation. My title for today is Partial Extraction Therapy using R2Gate and a Prefabricated Provisional to reduce surgical and prosthetic chair time. I'll begin with a quote that has a theme for this topic, and it's give people wonderful tools and they'll do wonderful things. I think that we are blessed to have a company like Megagen that never stops innovating to give us great tools like some of the ones I'm going to mention today. Today's objectives are to understand challenges in aesthetic implant dentistry, to review quickly the protocol for partial extraction therapy, distinguish between an analog and digital workflow between the two cases, and highlight some of the advantages that the digital workflow has, as well as time-saving steps. When it comes time to doing any type of implant dentistry, risk assessment is very important. Here are some of the risks that are associated with an anterior aesthetic implant. There's many more, but things like tissue scallop, patient expectations, systemic conditions, and the smile line are all very important to consider before and during the treatment. Another three lines that are very popular and also give us an idea of the risk assessment overall are these. Bone sets the tone, tissue is the issue, and buccal plate sets the fate. Let's keep these in mind as we go through the lecture today. Changes after tooth extraction I'll go over briefly, but we all kind of understand that after an extraction there is tremendous collapse of the alveolus, as seen from the pictures behind, as well as some of these studies that have shown us over time. Most importantly for the maxillary anterior region is that the buccal plate can be very, very thin, and therefore the risk of relapse and a reduction is very important. So there have been to date multiple different methodologies that help treat anterior aesthetic implants, and most recently socket shield was introduced. It's basically based on root submergence, which has been studied since the 80s. And this socket shield technique was introduced in 2010 by Herzler and Zur. It's part of a group of treatments known as partial extraction therapy, and essentially the concept is to keep a thin buccal plate so that we can maintain hard and soft tissue morphology by maintaining the blood supply to the PDL and the bundle bone. I know many of you are probably already doing this. In a recent study by one of the leaders in PET therapy, Howard Gluckman, is that after 128 socket shield cases, he concluded that it performs competitively when compared for implant survival in both conventional immediate and delayed implant placement. I'll go over next the root membrane kit that's offered by Megagen. This is one of those wonderful tools that they offer for us. And as many of you probably already do this, I won't go into too much detail, but this video just shows you the steps on achieving a socket shield and how to place an implant in the correct position. So you start with a Gates Glidden burr to find the canal and the length of the working length, just like you would in an endodontic procedure. This is after you've removed the crown if it's currently present. With the initial shaper 1, you want to create a trough from the mesial to distal direction, and that will help you guide the mesial shaper 2 all the way to that working length to separate the buccal and palatal fragments. You gently remove the palatal fragment, leaving the buccal in place, and then you start to reduce the shield in thickness and sometimes in shape. So with a couple of round burrs, you're going to reduce this down until it's about 1.5 millimeters thick, and then start reducing it in an apical direction so that it is level with the crest of the bone on the buccal. This next burr, the final shaper 1, it only cuts on the end, and as you can see, it protects the gingiva as you are trimming down that last bit of the shield. And finally, the final shaper 2 lets you provide a bevel for the shield to give a bit more space for the restoration. You can go back to initial shaper 2 to start your osteotomy for the implant. And generally, you want to place these implants towards the palate so that they come out with a screw retain position, and they are also away from the socket shield. Here you see the sequence of drills for any ridge implant placement, making sure you're going to depth and keeping that angulation and direction constant. So as you finish the last surgical drill for any ridge, before placing the implant, you want to use this tapered diamond drill to just reduce the palatal portion of that alveolus a bit, so that when you place the implant, it does not get pushed towards the buccal and onto the shield. Here you can see an any ridge implant from Megagen being placed to depth, slightly below the level of the shield and away from the shield as well, before a temporary is placed and healing commences. So I know many of you probably already practiced this treatment, but for those that have not tried it yet and are curious, I highly recommend you do this, because the two cases I'm showing today are two of the first ones I had done with this technique and with this kit, and as you'll see, the results are very good so far. So the first case is an analog case. This one was planned. Aside from digital radiography, there was nothing digital about this case that we did. It's an 81-year-old male with controlled hypertension. He does have extensive crown and bridge work in the maxillary anterior, but dentally he's pretty well off. He has a supracrustal fracture of 2-1, and the plan was for a socket shield preparation, immediate implant, and temporization. This is him at initial presentation, his full smile. As you can see in the x-ray here, the 2-1 is fractured off. It is above the gum line, and we did explore some other options, including orthodontic extrusion and endo, but he preferred to have the implant therapy as the treatment. Here you can see the CBCT, as well as a version of it with a planned implant. This was not a Megagen implant. As you can see from the CBCT, the buccal positioning of the root, and also how thin and almost non-existent the buccal plate seems to be. So to me, this is a very good candidate for this procedure. Just some more cross sections of the area, as well as with an implant planned. So this is the day of surgery, occlusal view. Something to note is the buccal emergence or buccal prominence of the tissue that is a result of those roots. This is something we want to keep an eye on as we progress through healing. The crown is removed, and then the sectioning or the root preparation starts, the socket shield preparation. Here we see a mesial-distal cut. So this cut was not, as a mistake of mine, was not all the way down through the canal, and therefore the piece, as you can see, that I'm removing is not the length of the root. The root was much longer than this. So that left me with more of a palatal portion at the apex, which we had to trim away slowly with the burrs. So this took a little bit longer. But by this point, we have trimmed away most of the palatal portion. As you can see, the shield is starting to take this crescent form on the buccal. What's important as you're doing this is that you make sure that there is no movement of the shield that is a contraindication for this treatment. So by this point, I've reduced the shield to the final parameters, and we are ready to start with the implant positioning or implant drilling. This is the initial pilot drill, and I do notice that on the mesial aspect, I did leave a bit of the tooth there. Okay, that is another mistake, given this was one of my very first cases. But you can notice the palatal positioning. This is the final drill size before the implant was placed. The palatal positioning is very important to ensure that we can do screw retained restoration, as well as that it's not touching the shield. That's the osteotomy. Implant is placed. This is a Straumann SLA BLT implant. And we use sticky bone to pack the area of the jump gap. Even though it's a narrow jump gap, I believe that packing it is going to give us a better result. I used a provisional here. I made a provisional, but really in hindsight, I should have used his tooth that we had taken off. But either way, the provisional was placed here, screw retained, as you can see. And that's the final PA on the day of surgery, as well as the way that he leaves the clinic. 2-week healing, we just want to make sure that the tissue is having a healthy response. There is no sutures to remove, so nothing really needs to be done at this point except check on the patient and coach them with their oral hygiene. You can see the tissues are pink, firm, healthy, and healing very well. That is his smile at 2 weeks. As we follow him up a bit more, 4 weeks, we can see a little bit more maturation of the tissue. You can see it's holding a very nice shape. And at 4 months, several months later, we can see that the area has healed very well. And as I mentioned before, this contour is important to keep. So you can see even at 4 months that we have not lost any of the volume. That's a PA taken at 4 months as well to verify that the implant has not had any complications radiographically from the healing standpoint. Here we see the sequence of PAs, as well as kind of a profile shot to see that the buccal eminence of the tissue and of the bone and of the root has been kept. So another comparison, initial to 4 months. We did wait a little bit longer to the 6-month portion. You can see here that he's kind of chipped a little bit of his temporary, especially on the distal. But the most important part of the temporary, the part that's coming through the tissue, has been preserved, which is important. So at this point, we removed the temporary, and my biggest critique of my work here is that I overbulked the temporary on the distal. As you can see, the papilla between the 2.1 and 2.2 is not very prominent. It's a little bit blunted in that area. However, the central papilla does look quite good. We then took a customized impression to duplicate the temporary and take this impression. And then this is a 6-month view of the socket after we had removed the temporary. So you can see very nice tissue response. The implant is in a good position, maybe slightly distal. Maybe that's what led to also the blunting of that papilla. Not enough space there. And importantly, we have kept that buccal contour. So unfortunately, at this point, I did not see the patient anymore. He did get restored by his general dentist. I do not do final restorations for my cases, as I'm a specialist and get referred these cases. So that's case number 1, and we're going to get into case number 2 now, which is slightly different. For this case, as you'll see, we went through some digital planning. We used R2Gate, and we used some Megagen products, but the socket shield was pretty much the same protocol as before. This case is also quite different from the patient aspect. It's a 30-year-old female with a high aesthetic demand. Not only is the demand for aesthetics high, but also longevity compared to the last patient. Medical history is non-contributory. And the dental history is that she had trauma at age 16, followed by immediate root canal therapy, post-encore, and PFM crowns were done at both 1.1 and 2.1 at the age of 19. So she's had these teeth for 11 years, but my treatment planning process for this case not only involved the fracture of 1.1, which is subcrestal, and we'll see, but also involves thinking ahead and understanding that 2.1 may be compromised at some point down the road. Treatment plan similar as last one, socket shield preparation, only that we're going to place the implant with an R2Gate guided treatment, as well as temporization that's pre-fabricated. The restorative work of this case was done by my colleague, Dr. John Yoon, which you'll see. So this is the patient, initial smile. You can see a little bit of darkening around the 1.1 root, a little bit of extrusion as well. The PA, you can see that there is substantial bone loss. We don't know exactly if it's on the buccal or the palatal, but clinical measurements as well as the CBCT here shows that the fracture was on the palate, as well as the significant bone loss. You can see there where the number 1 arrow is pointing, there's a fracture of the root and a subsequent bone loss on the palate. So this is quite deep. And also what we can see here is that the root is quite prominent, just like the last case. You can imagine if we had to remove the whole tooth, there wouldn't be too much of a buccal plate left over. So we planned this case using R2Gate, which is Megagen's version of digital guided surgery. And I'm just going to run through this little diagram here, this little video clip of how R2Gate works, if anyone doesn't know. This is taken from my iPad. So essentially what you do is you send some information to the R2Gate planning center, and they help you plan this case. You send them an STL file as well as a DICOM, and in this case we also sent the shade for the provisional. On your iPad you can use your finger, you can use the Apple Pencil to basically change any parameter that you would like. You can move the implant around, you can change the depth, you can change the size of the implant. Okay, and there's many things that you can do here, and the beauty of it is that you can do this on your own time, and when you are ready you send it back to the planning center and you can confirm it and finalize the treatment plan with them. So I won't run the whole course, but basically what you see on the right there and in this next picture as well is what the products we got back from the lab. On the left is a surgical guide that has the implant that we are for the tooth that we are taking out, and also on the right we have a temporary that's prefabricated and milled. So day of surgery, she presents, and we had to remove the crown. In her case, the toughest part of the extraction was to cut around this gold post that was quite firm in there. And you can also even start to see now that there's palatal tissue inflammation from the redness. So after I got through to the root, or through to the post, we performed the traditional socket shield procedure with the root membrane kit from Megagen. As you can see on the picture on the left, that the portion that has fractured off, or the fracture is clearly evident on the palatal aspect. For this case, I was able to use the Gates glidden to get to the working length and cut appropriately so that the palatal portion, as you see removed, is the full length of the root. So further preparation of the root ends in this configuration where we have a thin buccal root left. It's kind of a crescent shape, so we're taking into consideration that potentially the neighboring 2-1 may be lost in the future, and we're hoping that part of that root is going to help us keep that interproximal bone there. So the guide is positioned. We want to make sure it's fully seated, and that helps guide us our first drill, which I took a PA and a photograph here for, just to make sure that the positioning is correct and the depth as well. These guides are also very useful because they have a window that help us with the timing of the implant that allows us to pre-make these restorations, as I'll show you. But this is Megagen Any Ridge implant, and as you can see in the picture, as long as the green part of that driver lines up in the slot of the window and the horizontal line lines up as well, that means that we have a positive seat in terms of positioning, but in terms of depth, as well as the timing of the implant in terms of the internal hex. Here's a visual of the implant. You can see it is close to the shield on the mesiobuccal, but definitely not touching the shield. So this provisional, which was provided by the lab, is we used this to make her provisional, but we had to make a few touch-ups because the shade wasn't perfect. But aside from that, it does save a lot of chair time because the metal portion is already highly polished, so that's very important in terms of tissue training. But also just the shape, the contacts, the occlusion, all things are much closer than if you were had to make this on your own. In the picture in the middle, you can see that a healing abutment is placed and a sticky bone is placed around as the grafting into the gap before we place the provisional. So the provisional here is inserted with a PRF poncho, is what you see at the top there. And that's how the patient leaves that day. As you can see, I tried to add a bit of composite to try to match the shade a little bit better. And on the left is the PA of the insertion. So patient leaves that day, returns 4 weeks later. She did see Dr. Yoon, my colleague, to get the provisional touched up a bit. Obviously, he did a much better job with it than I did. And at this point, we honestly could have already taken the final impression, but we did want to wait a bit longer for healing and just for myself to see how these cases turn out. So this is at 8 weeks. You can see the tissue response is very good. Even though she has slightly thin tissue at the front, you can see that the shield has really helped us keep that tissue in place, the occlusal view. And at 4 months, we took a PA to verify the health of the implant. Everything looks the same as we had left it the day of surgery. And here we are ready to take our final impression. So this is a custom impression. You can see the healthy tissue from the healing around the temporary, and you can see the shape is quite ideal. You can also notice the buccal bulge, that the tissue means that the tissue is very thick and robust. Like that. So this is the custom impression, And you can also notice that on the laterals, the 1-2 and 2-2, Dr. Yoon did some composite work to get those to look a little bit more even. So this next picture is the crown delivery. You can see a little blanching of the tissue on the buccal, but that shape is still kept very well from the occlusal aspect. This is a final PA on crown insertion, and then I have some, after this I have some follow-up, but this is the PA sequence from the day, from initial to surgery, 4 months, impression, and final. And here, 2 months post-insertion, you can see the tissue is no longer blanched. It has settled down. The shape is still exactly the same as it was before we took the tooth out. So that is excellent. Here's the 2-month post-insertion. Shape was not perfect, but close enough. And you can see a comparison for initial and final. This is her smile from before to 2 months post-insertion. Okay, so I'll conclude with just a few points here about saving time with digital workflow. As you can see between the two cases, for case number 1, there's not as much pre-surgical planning. I mentioned we took a CBCT and that's really all we had. But with case number 2, there is some more pre-surgical planning, but it saves valuable chair time. So it's the difference between spending time with the patient in the chair versus not. Case number 2, the implant surgery was much faster. There was we used the R2Gate guided drilling system. The drills themselves have stoppers with them, so we know exactly which ones to use, and we can do the drilling very, very quickly in a matter of minutes. It's also more accurate because it's digitally planned, and we don't have to rely on our vision and our feel for getting the position exactly right. And finally, the prefabricated provisional, which is probably the part that saves me the most time because that is definitely not my strong suit, but making provisionals I understand is very important, but it does take a lot of chair time. And with the metal portion of the abutment being polished already, it just saves you a ton of work, even if you have to make some adjustments like we did to match the shade a little bit better. So I'll conclude there with this picture, and this picture actually was painted by patient number 1. He is Mr. NB, and actually I wanted to dedicate this lecture to him because I unfortunately just found out that he passed away today. So this is in memory of Mr. NB, and thank you for your attention. On the screen you can see my email as well as my Instagram handle if you want to reach out to me. Again, I want to thank Megagen and the MINEC team for allowing me to present my case here, and I hope you all got something out of it. Thank you.